Good afternoon to all. My name is Marcia Borges from the hospital in Palma de Mallorca, and I first want to thank the organization, Pablo Alessandro and all our colleagues and Pepinti, for inviting me to participate and to moderate an excellent panel and with three very important speakers with an international level and associate professors in their corresponding universities. And these are three great friends for a very long time. We're going so that we organization is easier. The three presentations are going to be in Spanish, and the first session, the first talk, will be by Dr. Ricard Ferrer. Dr. Ricard Ferrer is the director of the critical care area in the Valdebron Hospital in Barcelona. And also, it's an honor. He's our current president of the Spanish Society of Critical Care Medicine, Simisiuk. And the second session will be in charge of Dr. Javier Perez, the medical director of the Department of Critical Medicine of the Baptist Hospital in Miami, and also a member of the directors of the FIPINCHI. He will give us an update on ventilation associated pneumonia. And finally, I want to thank Dr. Rafael Zaragoza. Last minute, we asked him to help us for the session. He's the chief of service of the hospital, University Hospital in Valencia, Spain, and coordinator of the research group on hospital pneumonia, hospital-acquired pneumonia. Talk about the current limitations of the treatment of hospital-acquired pneumonia. Good afternoon, good morning, good evening, depending on where you are. Greetings to all, and thank you very much to this organization for the invitation. From a topic that I will talk about are inflammation and pneumonia that complicate COVID, especially. And that is the topic that we're all occupied with. And we will start with a clinical case, a 58-year-old patient without any comorbidities. He was hospitalized during March, received treatment with antibiotics and antivirals. He was in the ward and finally required admittance to the ICU. He received flow, intubation, three prone positions, and presented three complications: two infectious, the first ventilation associated pneumonia with negative culture with metapneumonia, then pulmonary embolism with coagulation, and finally another episode of hospital-acquired pneumonia, mechanical ventilation pneumonia. And as you can see in the X-rays and the CT, it was treated empirically with meropenem in isolation, sensitive to cephalosporin, and was ended with nebulized colistin and cefotaxime. But this is a bit the clinical presentation that we are discussing today. As you know, this is an experimental model, and these are electronic microscope images. This is the SARS-CoV-2, and these are 96 hours post-inoculation and produces millions of ions in the alveolar epithelium. This is expressed as an infection, a very mild infection, moderate or severe, with the possibility of evolving from one to the other, and with the possibility of evolving correctly or truly evolving fatally. And you also know that an important role in this is the inflammation of the host, because the inocule of the patient is the same virus. And what changes is the different phenotypes change depending on the immunity. It's a protector, adaptive immunity that fights against the virus, or it's not regulated in hypercytokinemia, and it activates the coagulation, and there's organ dysfunction. And this is what we can see in the lung: production of local edema, activation of the endothelium, the alveolar endothelium, and then you can see the capillary, the pulmonary capillaries being affected. With the group of Jesus Vermeso and other researchers in Spain, we described the patients, the critical patients, with greater viral load, greater percentage of viremia. This is translated into the inflammatory response that is exacerbated, that you can see to the right, with the cytokines and inflammation markers that are increased. And these translate into the final paper, what I showed you. Uh, it is a draft, but the paper has been accepted in critical care. And what we're showing here is the wrong control of the immune system, viral load increased in plasma, and an exaggerated inflammatory response with endothelial dysfunction, activation of the coagulation, hypercytokinemia, and local tisular damage. When we see this in terms of inflammation biomarkers that we can measure routinely, such as procalcitonin, it is also a biomarker that usually is not elevated in viral infection, but when it elevates, it is a biomarker. That's pollution. It increases the risk by 5 times of having bad clinical outcomes. This hypercytokinemia that has been discussed a lot, we have tried to control it with monoclonal antibodies. In fact, it is hypercytokinemia that is not as increased as with other pathologies that we see routinely, especially in third level centers, of the cytokine release syndrome that has a cytokine cascade that is fixed with monoclonal. This hypercytokinemia is related with COVID, and we expect that it can be controlled, but this is a topic perhaps for discussion. We also know well that patients with some risk factors such as hypertension, diabetes, advanced age, obesity, these patients have a worse clinical course, and it's related with what we're talking. These patients most certainly have an endothelium that is pre-activated because of the diabetes, hypertension, or obesity that favors this second damage. And we could also describe between colleagues here in Spain and Italy a certain genetic predisposition expressed as polymorphisms in genes in chromosome 3 and chromosome 9 that favor severe cases of disease, of COVID-19 disease. This slide was shared by Marcio, and antivirals, immunomodulation, where we have corticosteroids, anticoagulation, and some specific phenotypes, the use of monoclonal antibodies, and hemoperfusion with even more question marks, and then support therapies that I believe are, from the point of view of critical patients, that mark the evolution of this disease. In other words, having an available ICU bed and the possibility of having access to ventilation support is a factor that we have as a factor that is the one that determines the mortality of this infection. There's great variability in this survey that we did last summer, great variability between applying the different treatments between different continents and different countries. This means we don't have a standard of treatment still. And these patients have risk factors for intra-hospital infections, age, comorbidities, mechanical, prolonged invasive mechanical ventilation, organ dysfunction, and the use of immunomodulating medications and COVID immunodepression are factors described in these papers that you have below that are associated to a higher risk of disease and intra-hospital infection. We have seen these charts. I showed you the first clinical case with a patient with mechanical ventilation associated pneumonia, and the pulmonary circulation has problems because of embolism, thrombosis, pulmonary infarction. This also shows more complications of pneumonia in the form of necrosis. All viral pneumonias, as you know, have a local inflammation of the epithelium, pulmonary epithelium, at the different levels. And this is a factor that favors colonization by different bacteria and bacterial co-infection. And this is common with all viral pneumonias. If we also bring to this the alteration of the immunological status, as we see in patients with COVID, with lymphopenia, etc., and the large production of mucus that complicates mechanical ventilation and demands to have patients that are very intervened in terms of bronchoscopy, etc. This is all a substrate that favors the appearance of co-infection or superinfection. And co-infection appears more frequently in viral pneumonia than in COVID-associated pneumonia, no, pneumococcic or staphylococcus pneumonia in influenza, and much less in COVID. The Spanish group described in this sequence of several years analyzed co-infection in critically ill patients with influenza and a variation from year to year. And co-infection in general is relatively frequent, with pneumococcus in this series the most important one, associated to co-infection to greater mortality. 30 to 65% of the cases, depending of whether you look at studies in China, infection of around 3.5%, superinfection of 14.3%. And what's important of this Canadian meta-analysis is that 62% of the patients were receiving antibiotics, despite the fact that co-infection was not as frequent. So there's a factor to modulate the treatment, and there's also heterogeneity in terms of the use of empiric antibiotics when the patient comes in with pneumonia due to COVID, to reduce the use of the antibiotic pressure. In the graph to the center, if you look to the left, these are patients that have an EFG. Under the cutting line, there's lower use of antibiotics compared to the patients that are to the right that have PCT over 25, where they used antibiotics more frequently. If you look at the mortality in the graph to the right, this group with a lower PCT, lower use of antibiotics, mortality has not increased. And we can translate that this is probably a safe practice to use this biomarker to rationalize the use of antibiotics. In terms of the diagnosis, perhaps ultrasound can be useful at the bedside. At least in this Italian study, they associate the clinical diagnosis or it coincides with the change in the radiological pattern from interstitial to consolidation. So this is one of the tools. It's complicated to move the patient to a scanner, but we cannot do it every day. But the ultrasound can be used every day. So these ultrasound can have an important role. This is our experience during the first wave: 330 patients in the ICU, 250 in mechanical ventilation. Out of the 251, 100 developed VAP. Half of these due to gram negative, and then some they were positive, and anecdotal one some, but 13% were necrotizing, and the other ones were multi-resistant microorganisms. What are the risk factors in this adjustment by propensity matching? The use of corticosteroids are a risk factor to develop VAP. So tocilizumab, non-matched or non-adjusted, and when we adjusted the doses, it loses significance, and we only have the corticoid. But immunomodulation, as well as other factors, can explain a greater number of infections. And if we look at the outcomes, mortality goes from 15 to 25% in the group of patients with pneumonia. So it seems to be that mortality associated to pneumonia could be around 10%. This pneumonia usually appears between the second week and logically increases or reduces time until death. In terms of treatment, we have the risk factors from the American and European guidelines for treating hospital related infections to approach pneumonia and COVID. I believe that local ecology plays a very important role. So we need to be very aware of this, especially if you have to expand ICUs in an important manner and if you work in areas that are open to be able to manage all the COVID patients with a single space. Infection here could be greater multi-resistant spreads are more important, and you have to consider this in your empirical treatment for these infections. That we'll have a session dedicated only to this topic. So I believe that I am more or less on time. I want to tell you that I believe that bacterial pneumonia is a common complication of severe COVID-19. Some studies report high mortality. Gram-negative bacteria are cause of pneumonia in COVID-19, and multi-resistant bacteria should be considered in certain settings, especially open settings. Necrotizing pneumonia, sometimes severe cases. So a strategy for antimicrobial stewardships and infection control are essential during the management of these patients. Thank you very much. Go to the second talk, Dr. Javier Perez.
Well, we're going to talk a little bit about the management antibiotics, the antibiotic aspect of VAP, ventilator associated pneumonia, that we have mentioned before. We have talked about something that Ricardo already mentioned a little bit about. It's the fact that VAP, ventilator associated pneumonia, and hospitalization related pneumonia are one of the most frequent conditions of nosocomial infections, occupying 1/4 of the whole of infections. And this represents a serious increase in the morbidity of the patients, and of course, an additional cost and an increase in mortality. As we have mentioned earlier, Ricardo already mentioned this, there are two types of infection. One associated to the early onset to VAP, less than 4 days, which generally is associated to less virulent microbiological environment, generally comes from the community, and it's much more sensitive to antibiotics. And that which is acquired in the hospital beyond those 4 days, it's more virulent, and it generally has a greater proportion of multi-drug resistant germs. This was also mentioned by Ricard, and differentiation of early onset or late onset of the infection, the type of germ that are associated to these types of infections. As we can see, Pseudomonas and resistant Staphylococcus are much more frequent in the hospital setting, and Staphylococcus, but non-sensitive Staphylococcus is much more frequent in the community setting. So it's much more early onset. We have talked about diagnostic criteria for a long time, and the first invasive ones are the preferred because they're much more adequate and they present much more specificity on the type of germ that could be associated to this. And here are the values that are generally used. Obviously, once again, using microscopy as a bronchoscopy as the preferred method to do the evaluation. So a couple of questions that always arise. We will continue talking about what the guidelines say. So if the quantitative cultures should be done, and to continue with these thresholds that we have talked about, this threshold criteria to be able to remove or decrease the use of antibiotics or to continue with the antibiotics if the case arises. And the Americans, we can and should de-escalate antibiotics once we find that the number of colonies doesn't comply with the adequate infection threshold. Although this is a weak recommendation and based on very little evidence, so we still have the same controversy. And the reason why this is recommended is because the use of antibiotics also generates a damage and it increases the costs as well. So we always need to look for an alternative to the could be sick if it's not pneumonia. Of course, we need to be aware the patient has received before bronchoscopy. In case bronchoscopy was elected, we need to determine the presence or not of a severe sepsis and the fact of having or not a favor the de-escalation of medications, in this case of antibiotics. So it's a very weak recommendation. It's filled with controversy, and I don't think that this has solved anything. It hasn't answered anything. So those patients where we suspect pneumonia, which is not necessarily associated to mechanical ventilation. So the question is, should we always do a bronchoscopy, or can we do an empirical treatment? And the recommendation, once again, is to do some type of tissue sampling, or sampling of secretions. But once again, this is based on very little evidence. And once again, we go back to the same topic of the de-escalation of antibiotics for those patients where we noticed improvement, or in those places where the cultures have negative levels. And there is a determined aspect in the recommendation guidance with regards to the use of non-invasive methods. Non-invasive methods, normal spectoration of sputum, to be able to suction it endotracheally without doing the bronchoscopy itself. So with those patients where we suspect, once again, a pneumonia, what is the role of procalcitonin in these cases, and if it should be used as a standalone clinical criteria to decide whether to initiate or not antibiotic therapy. So the criteria is that the guidance preferred to use the combination, the expert's recommendation is to use the clinical criteria without including procalcitonin, which doesn't really add much value. And this is a strong recommendation based on moderate amount of evidence. So we should not expect or wait for a level of procalcitonin to begin with antibiotics. And there's a lot of evidence with regards to this. The early start of these antibiotics empirically, even especially if you chose the correct one, if they are directed to the more specific flora that biota, which has a added value to the survival of the patients. So the patients, once again, are there any other clinical criteria or diagnosis that we could use or not? Once again, the guidelines prefer to go back to the clinical criteria before using markers, which are much more expensive, much more difficult to obtain, because they don't contribute with a lot more. And it's a lot more important to begin antibiotics early, especially empirically and directed. And that's the most important thing. There are some clinical criteria or markers or modifiers or quantifiers, such as the clinical pulmonary infection score calculation, which has been used as a diagnostic tool, an adequate diagnostic tool, to determine that a patient in ventilation has developed pneumonia or not. And the question the guidelines ask, and this should be something that we use universally or not, and the answer, once again, is that it doesn't contribute much to the clinical suspicion that we have previously determined, and we should not wait for the possibility or an increase of the CPIS score to increase empirical antibiotics in those patients. The other answer is something that we find very frequently in our patients who develop a tracheobronchitis associated to the ventilator, but they don't have pneumonia criteria. There are no infiltrates. There is no decrease in oxygenation. So once again, the guidance of the American Association recommend not providing antibiotic therapy in these cases, because the bacterial selection increases and because there's not much evidence that this will later translate for the development of a VAP. The other big question is if empiric antibiotic regimen for VAP be guided by local antibiotic resistance data, or should they be used according to the data that each institution or hospital has. And I think that this is correct. We need to be aware what type of biota exists in the hospital and in your community to determine what type of empirical treatment we should develop. Once again, we talk about many of the articles that have been very useful. Mary Kolev, Niederman, who have pointed out in several studies that the use of antibiotics, empirical use of antibiotics, but directed to the adequate biota, if they are correct, they increase patient survival and decrease complications. This is something that is clearly determined. And if we're going to use empirical antibiotics, we have talked a little bit about this already. But if we are looking for the Staphylococcus aureus or Pseudomonas aeruginosa, we're going to use gram-negative bacilli. And we need to use antibiotics that are adequate to the pathogen biota of the community. So the use of an antibiotic to methicillin-resistant Staphylococcus aureus or MRSA, it's interesting because it opens the door to thinking that many of the areas where we work, more than 70% of Staphylococcus are sensitive still, and medications Venezuela have very little activity against sensitive staphylococci. So it's very important not to forget about this aspect. And I think this is the most important thing of this slide, which is a bit overloaded with information. Of course, the use of two antibiotics in the case of Pseudomonas continues to be a basic recommendation if it exists, especially if there's a microbial resistance of Pseudomonas in the environment. If more than 10% of the gram-negative isolates are resistant um, to the agent that was considered for monotherapy, or if there is a lack of knowledge of, of the proportion of the agents, in this case, the Pseudomonas, which are resistant in the community. We are talking in every case, two anti-Pseudomonas agents are recommended, but it's a weak recommendation because there's knowledge lacking in this space. Once again, when there's less than 10% of gram-negative isolates which are resistant, the use of a monotherapy should be considered against Pseudomonas, but once again, with very little evidence, and it's a weak recommendation. The use of colistin or aminoglycosides to treat gram negatives, if they're available, well, it's a recommendation that is issued, but once again, based on very little evidence. And this is very important as well. It's very important to shorten the treatment as much as possible, because in many institutions, we have the appearance of C. diff and Clostridium difficile, which has created a lot of problems in our institutions. And we need to monitor, individualize in every particular institution and determine effectively what is the best treatment and the most optimal treatment. Another of the situations is if we should continue with the recommendations of the manufacturer to determine the dose, or if we should do what we call the pharmacokinetics and pharmacodynamics to measure the levels in each patient. And this is a recommendation that the societies issue, but once again, based mainly on expert opinion and not so much on evidence. Lately, we have a series of products which are inhaled products. The use of inhaled antibiotics is increasing or is catching our attention more, and the guidelines talk a little bit about this. However, they don't they don't give it too much protagonism, and they are available. They may be used, but it's not common in all hospitals or in all institutions. It's not available for everyone, and we need to study this more in depth. 7 days or 15 days, 7 or 14 days, the longest or shortest antibiotic course. I think every day there are more answers to this question, and that the recommendation that the shorter course has more effect because the duration, and they're going to have infection associated to Clostridium difficile, as we mentioned earlier, and that is important, especially if there's an improvement from the clinical standpoint, radiological standpoint, or even from arterial gas tests in this patient. And once again, in the hospital nosocomial or hospital acquired pneumonia. And once again, the other question is de-escalation. So I begin with 3 antibiotics initially because I suspect that I could have Pseudomonas I could do a dual therapy for pseudomonas and also suspect the presence of a resistant staphylococci, and I will apply, for example, the mesolide. So in this case, I can de-escalate, and should I de-escalate? And the answer is yes. But once again, there's not so much evidence of this, and it's a great recommendation on behalf of the expert that once I have evidence that there are not no gram positives, for example, in the bronchoalveolar lavage, in the or any type of tissue sample, bronchoalveolar tissue sample where I don't have any presence of gram positives, well, it's adequate to eliminate that coverage, and vice versa. If I don't have evidence of gram negative, well, we eliminate it in way, or we could go to a dual therapy. And this is what the recommendation says, but with very little evidence. Once again, procalcitonin has value of this, and it could help us to determine if I can discontinue the treatment for the patient that I began empirically. So using procalcitonin 2 days afterwards, procalcitonin is negative, and this helps me in analog, and it can help us. And the guidelines recommend that perhaps we could use it for this value, but that in reality, this is a very weak recommendation with very little evidence, with low quality evidence. And the other question is if this could help me determine that I can discontinue the treatment on the seventh day instead of continuing the treatment for 7 more days. Remember that the risk factors are related to the patient itself, but also many times they're related to the type of instrument that we're using right now. In this case, the ventilator, the tubes or the tracheostomy and other tubes that we're introducing in the patient through the oral cavity. And it's very important to wash your hands. I think this is something that we have all experienced around the COVID epidemic, where the patient care has or the hygiene has decreased because of the number of times the nursing personnel came in to take care of the patients. As this has increased the nosocomial infection rates, which is concerning. So I believe that it's very important to remember that there is a complex to prevent VAP with basic criteria which are enumerated in the slide. Elevation of the head of the bed in between 30 and 45 degrees to delays sedative interruption, or what we call a sedation holiday, to determine if the patient is ready for extubation. Uh, the use of what we call the stress ulcer disease prophylaxis and prophylaxis for deep venous thrombosis. And of course, the last criteria that helped us a lot, particularly us, was to add daily oral care with chlorhexidine. Until 2020, we've had one VAP episode in our hospital system from 2012 to 2020. So this is one of the first hospital systems in the US. We achieved 0 VAP cases. There have been many other hospital systems which have achieved this, and the criteria that the Medicare centers have established have changed the criteria, and it's no longer called ventilator-associated pneumonia, but condition associated to ventilation. So the ventilator-associated condition is defined that after the patient is stable or improving in the ventilation parameters, at some point you need to modify the ventilator and elevate the parameters for whatever reason. This is a condition associated to ventilation. This ventilation associated condition, if there are signs of inflammation, infection, it becomes an infection-related ventilator associated. The criteria of the organization of the US, they have disappeared, and we're talking about IVAC, infection-related ventilator-associated condition. And in 6 years, we had no infections, no ventilator-associated pneumonia, and this made them change the term for any type of infection that arises in these patients. And this has been associated to 2 additional components, which are the change, as you see at the end of the slide, in the last line, the change of the nasogastric tube to the gastric tube, to the autogastric tube, and to make personnel or the staff wash their hands as part of the bundle, protection bundle against VAP. Thank you very much for your attention, and I will be available to answer any question. And once again, Marcio, thank you for this opportunity.
I'm going to talk about the risks of a patient, a ventilated patient, a patient at risk. A patient that is ventilated is a patient at risk. And I think we have many limitations in terms of the management. These patients are at risk of multi-resistant infection, be inadequately treated, develop resistances during treatment. Of course, the costs are going to increase, and they also have the risk to be patients at risk. And we have limitations as well to change our attitude, the hospital barriers to change, that the guidelines are very good, but they only appear every 4 years and they're not completely updated. The inhaled therapy, well, they spoke a lot about that prior colonization, not having fast microbiological techniques because they would make our life much easier. Also, the available antibiotics, sometimes we use them because we don't have any other, and because we don't know about the new ones and we don't use them. And my position. These are the data on multi-resistance in the national surveillance studies he used. And if I gave meropenem to a patient and I have meropenem, I may make the mistake if I use combined therapy. These are data of resistance in the last year, and the same thing happens for levofloxacin, we have 26% of the isolated strains. And you know that this is the most frequent microorganism of hospital acquired infection, as well as the mechanical ventilator associated one. And these pseudomonas are progressively more resistant. These are our data. And up to 4.4 in our Spanish series, they are resistant to colistin. We also know that patients with Pseudomonas aeruginosa that are bacterial, whether they're resistant to carbapenem, they have higher morbidity than if they were sensitive. So we need to have this landscape because we need to know about our local flora to be inadequately treated, especially when the patient is extremely severe. Unfortunately, to be correct the first time with the adequate antibiotic could increase the survival. But unfortunately, the pseudomonas, and we have them here, are the most frequent organism that is not treated correctly or is inadequately treated. We also know that patients that are escalated have higher mortality and those are that are de-escalated. And in Pseudomonas, but also in other microorganisms, we know in Palma de Mallorca, where they have taught us that secondary resistance to Pseudomonas is greater than the primary resistance. And this is associated to the fact that they're hospitalized for a long time in the ICU, that there's prior isolation in patients to Pseudomonas aeruginosa, or that they're treated for a very long time. And with all the antibiotics, with the majority of these, of course, with beta-lactams, it can happen, but it seems to be that it happens less with cephalosporins, and it happens even less with quinolones. But what is clear is that the longer we treat the patient or the patient with inflammation with Pseudomonas aeruginosa with an antibiotic, the higher probability they will have of developing resistance. And we have meropenem with piperacin and ceftazidime. And of course, that these are data from Valencia. Infection from Xeromonas aeruginosa increases the costs, of course, and the longer hospital stay, and the costs increase even more. The patients have a multi-resistant strain. Now, we have developed this in the paper that we published recently in our group that talks about the risk, and we say it in our units. But the problem is when a patient develops nosocomial pneumonia, is that they don't cough out the mucus, and that happens both in the wards as in the ICU. You have the progression from green, less severe, to red, very severe. But if your treatment fails in the ward, and we can analyze this during the discussion, and then it becomes hospital acquired pneumonia and later ventilated acquired pneumonia. And this ventilated hospital acquired pneumonia is worse than the one associated to mechanical ventilation. Well, this graph from Nacho Martin Benitez, a hospital acquired pneumonia may require 20% of the cases mechanical ventilation and with deaths of 31%. So it is an entity that is very severe or serious, and we didn't have it until a short while ago. To learn about when this pneumonia can be developed, normally the first few days of risk, that can possibly help us be more aware of it. And then, of course, in we they asked us to review each one of the risk factors for the more frequent organisms isolated in pneumonia, and there are differences, but perhaps alcohol, and here you have them described, and we need to consider all of these. And I spoke about risk already, and in change of barriers to change at the hospital. Most probably, we may have problems in terms of pharmacy, the pro center groups, resistances, and the local flora that we have, lack of knowledge of new medications, or even that we're limited because of their costs. If you look at this table of antibiotic use from last year, and the new medications, there are none that we should more frequently use. And if we look to intra-hospital or intra-ICU treatments, they used some of the new antibiotics that we lately have, that are beta-lactams and cephtalins. And the guidelines, we did this 11 years ago. This was a guideline from our group work and the intensive society in Spain. And when we have VAP suspected, it could be gram negative, we did combined therapy, this with glucoside. And you could think about the use of combined therapy. I have a problem with my presentation. And we could think about the use of combined therapy. If you confirm the microorganism, you could de-escalate. And if you had a multi-resistance, since you didn't have any other thing, you could have continuous infusion and colistin, otherwise standard therapy. This was in the year 2016 with the its guidelines has changed a bit. Even though it is true that in these guidelines we had the concept and the treatment of hospital acquired pneumonia associated to ventilation, to reinforce the idea that the European guidelines have, that they consider that it is very important for the empiric treatment, that you know your local flora and the risk of multi-resistant microorganisms, and that the patient is not in septic shock. Javier mentioned this, and the American guidelines, they suggest when you don't have any other thing, the multi-resistant antibiotic and mechanisms, and use colistin. But here we intervened as well, and there were no differences in mortality. But it seems that it eradicates it before, and when it eradicates it, it reduces the incidence for the appearance of resistant strains. Well, prior colonization, we have always thought that this is a prior step. We have colonization, then bronchitis, mechanical uh, VAP, and then if we have a prior microorganism, it is necessary that we can look at the colonization, but it's not enough. And this paper with the criteria that Javier mentioned in events associated to ventilation, only 6% of the patients that had prior colonization developed pneumonia associated to mechanical ventilation. The fast techniques, we have the luck in our hospital that have we have microbiology 24 hours a day, so we can use gram stain. We have other fast techniques as well. But even though in this paper from a long time ago, from 2017, to guide your therapy through this way, It came out better for the patient than if you guided yourself by the gram. And when you review meta-analysis of the gram, it has sensitivity and specificity that we would like to be higher. So we do it, and the use of plate to identify the germ. This decreases the time for the inadequate treatment. But the experts tell us to use fast microbiological and molecular techniques. Hopefully, we would have this available, that in the exhaled air, that we could identify the microorganisms that are affecting our patient. We don't have that, but we do have things like a film array that have a negative predictive value that detects microorganisms that are associated to our pneumonia and that don't that have an important negative predictive value. We need to know for the regimen that they recommended before our work of Panucci, they asked us to please show the antibiotics that did not appear in the final algorithm, and we should have a table. So the first thing, perhaps these are many, 9 clinical trials in nosocomial pneumonia in the last few years, and we don't have Tegacicline, Domipanem for the same reason, Septamiprol, because in VAP there's no inferiority. We highlighted the importance of lactobactam. We destroyed, or not destroyed, but the role of colistin was we need to use it when you don't have any other alternative. These are old data where you have patients with infection by pseudomonia and VAP treated with colistin. They have a mortality of 53%. And in this clinical trial where we intervened a couple of years ago, it was published last year. What it says is that colistin, we had to stop the trial because of the higher toxicity. So we couldn't see if it reached non-inferiority. We thought back then those that had beta-lactam that was that the combination, the synergic combination of meropenem with colistin in vitro could also be in vivo, and we used it. But this paper recently published also shows that it's not true. The fentosine avibactam is also another thing we have available, and we have another therapy that probably for could be choice for pneumonia. And we have to learn about the new antibiotics. I'm surprised when I see that for multi-resistant, if I use ceftolozane tazobactam, I cover with more possibilities and I make less mistakes than if I combine several drugs. This is another in vitro study that corroborates that. And we have data that are not clinical trials in real time that give us mortalities with the new medications for certain microorganisms lower than the ones that are currently reported. The same thing happens in this other study that, in other words, we need to open another door to the new medication. So our position is the following one. And was to think that we need to work a lot in adding the new drugs and place them where we consider that they could have advantages. In our case, the advantages associated, we believe for Pseudomonas aeruginosus, we need to use lactobactam, and for those that have a predominance of Klebsiella, the use of an empiric treatment or a targeted treatment. So I'm available for questions. I went very fast so that we could have some debate. Thank you very much. So with regards to the topic of immunomodulation with COVID,
All the modulation treatments in the case of COVID, well, you have evidence. Do you believe that there will be something with regards to this? And second, this could be the door for the eternal immunomodulation in other cases of sepsis. Well, if immunomodulation is to work in sepsis, and in this case in viral sepsis, which is COVID, well, this is the perfect setting because we have thousands of patients or millions of patients with the same infection. So the heterogeneity factor on behalf of the microorganism is eliminated. We just have the heterogeneity on behalf of the host. And I hope that there are several clinical trials underway, and we need to look for ways to do predictive enrichment. So look for the subpopulation that could really benefit, and for that the use of biomarkers plays a very important role. I believe yes, but the design of the trials is key. That includes um, suppositions of patients of predictive enrichment, and they could be the ones that really benefit from this, and not include those who won't, and which will only generate noise in the trial and they ruin the results of the trial. Thank you. Javier, I have a question for something that we like a lot. You've done a very interesting review about the management of VAP and HAP. What do you think about the new diagnostic tools or new treatment and management tools? What do you think that this can contribute to improve patient care? Because if you've said the majority of the points that you talked about diagnosis, treatment, etc., they continue to be the same as 15 or 20 years ago. So where can new technologies can contribute or improve patient care? Excellent question, Marcio. Thank you for this. I think definitely if we observe the different guidelines in the things that we're doing, we go back to the basics almost every time. So it's time to reflect that it's been 100 years since the last pandemic, and the control measures of this pandemic were the same as 100 years ago: social distancing and wearing a mask. And that's what we're doing right now. So it's important that the classical things remain. So the clinical aspect is very important as well, in my opinion. One of the things that helps us to diagnose infections in any type of patient is clinical trend. For a clinician, it's very important the daily observation of what's going on and observation at the bedside. The new technologies that you have talked about will help us a lot, because this type of monitoring, this type of control takes care, plays in a more precise way, which allows us with the use of AI, for example, in the future and currently, to be able to determine this type of criteria. And it's interesting because nowadays we know that the use of AI goes beyond the regulating traffic in some cities, even though it seems impossible. Incredible artificial intelligence can help us to determine how a patient will behave in the next couple of hours based on the historical evaluation of millions of patients, something that one of us could not do. So this is a very interesting field. The small clinical changes that we uh, behind these studies. So for those who are watching, how can you update this and do a customized treatment for nosocomial pneumonia? How can we differentiate between the traditional clinical guideline and, for example, what you have proposed? I think that the consensus documents, the documents from the experts, exist for that, to cover our day-to-day reality, and to cover what doesn't appear in the guidelines. I will use a phrase that Ricardo uses when we talk about this, and it's for evidence in the guidelines about a particular pathology. We can have this, but we go down to the microorganism level. Well, a certain microorganism would be much more difficult and would be low evidence, weak recommendation. So with this type of meetings, with this types of documents, the only thing they want to solve is the day-to-day, the problems in the day-to-day practice. Okay, I would like to thank you. We are just in time for next session. I just wanted to thank you. I've learned a lot. These were very exceptional presentations. It couldn't have been otherwise having the three of you here. And would like to thank the organizers, and more specifically Pablo Alejandro Gardinao, who has been the father of this fourth day of World Lung Day. Thank you very much, and I would like to thank you for attending. Thank you very much, and take care. Thank you.